so.
Ah. Okay, we'll live.
We're going to put the light on, not put the light on.
Fine.
Out of your face.
Fine.
So,
We can live with it at that level.
prizes, okay. We're good.
Okay?
I'll introduce you if you want me to.
Yeah, why don't you?
Good evening, everyone. This is Dr. Gary Kaplan. I would ask two things of you. Please make sure your cell phones are either off or on vibrate. And please hold your questions until the end of the lecture. That's why we've given you the handout. You can make some notes so you don't forget something that you want to ask in the first 5 minutes. And then 5 hours later, you'll have a chance to answer, to get an answer.
What's your home phone number?
We'll talk later.
Dr. Gary Kaplan.
Thank you all. It's a wonderful turnout, and I appreciate everybody coming out tonight. This is the second in what's going to be a series of lectures on ending chronic pain. We have a very different concept of what pain is and what depression is. And that's evolved out of the research, particularly in the last 5 years. And so we have a completely different way of approaching these problems. And we think of pain and depression as two very different things, when in fact they're not all that different. So the concept is that pain and depression, anxiety, post-traumatic stress syndrome are symptoms. Okay, this is a very different way of thinking. We think of depression as a thing. We think of pain as a thing. We talk about fibromyalgia. We talk about neuropathic pain. All right, but really what they are is nothing more than symptoms of an underlying common neurologic process, which is a neuroinflammatory process in the central nervous system. So chronic pain and depression, anxiety is caused by an inflammation in the brain. These issues are neuroinflammatory, they are neurodysregulatory, they screw up the way the brain works, and most importantly of all, they are neurodegenerative. Okay? Things get worse the longer they stay in the system. All right? And the reason we started to think about this is because if you look at the chronic pain population and you look at the depression population, what you find is there's a massive overlay. That in fact, the overwhelming majority of people who have chronic pain have depression. The overwhelming majority of people who have depression have chronic pain. And the reason for that is this underlying neuroinflammatory process. And this is just to tell you that we know this because there are these inflammatory markers in the central nervous system that we're actually able to measure. Unfortunately, we can't measure them in the peripheral blood because of contamination from peripheral factors. But if we want to follow them, we can do spinal taps, which we're not doing, but have been done repeatedly over many, many studies in the literature. And increasingly, we're all coming around, we as in the medical profession, to understanding that these are neuroinflammatory diseases. This is the most important thing. If you look at these studies in long-term in people with chronic depression and chronic pain problems, you see loss of gray matter. The brain deteriorates. Over time, these things get worse, and they hit a point where there's not much we can do about it. I love working with my 20-year-olds and my teenagers because their tissue is so resilient that pretty much we can expect to see full recovery in these individuals. It is not as successful in our 60-year-olds and 70-year-olds. All right, we can certainly make improvements, but the sooner we get to this stuff, the better off the odds are that we're actually going to be able to get a full recovery. So we're just re-emphasizing this again: inflammation, dysregulation, and degeneration, chronic pain. Now, everybody wants the pill, and I wish I had one to give you to make it all go away, but I don't. What I do have is a process, and tonight specifically the process we're going to talk about has to do with nutrition and how we process the foods we eat. So specifically what we're going to talk about is metabolic syndrome, obesity, intestinal permeability, and I'll explain what that is as we go through it, celiac disease and gluten sensitivity, and then we'll give a quick overview and a somewhat shocking overview in terms of how severe the vitamin and mineral deficiencies are in the general American population. So let's talk first about metabolic syndrome. Metabolic syndrome is a combination of these things. So you have three or more of these things together, you have what we call metabolic syndrome. So if you've got a large waistline, men greater than 40 inches, women greater than 35. If your triglycerides measured on blood work are greater than 150, if your high-density lipoproteins, which is part of that lipid profile, so the LDL, the low-density lipoproteins, are the things that we really want to watch come down, but the HDLs, okay, this is part of the cholesterol profile. The HDLs, high-density lipoproteins, are the brooms of the cell. They're the things that help remove the cholesterol from the arteries. Hypertension, obviously a clear risk factor across the board, and then glucose intolerance. That is a fasting glucose greater than 100. What this implies is that if you've got lots of sugar spikes going on in your body, you have insulin spikes that go with them, and that's an inflammatory condition in the body. So you get 3 out of 5 of those, and you have metabolic syndrome. If you're going to measure your waist is actually not here. These are your hips. Your waist is, you feel where the lowest ribs are, halfway between the two of those, which really puts you close to your belly button. And you take the measurement around there, that's your waistline. And that's legitimately what you're measuring when you want to figure out whether or not you have metabolic syndrome. So how many people have metabolic syndrome? Lots. Over 20% of Americans of all ages, and if you're over age 60, over 40% of people have metabolic syndrome. It's a very, very serious and prevalent problem in the country. Why do we care about it with regards, well, let's go first for the causes. The causes are unquestionably diet, okay? Diet and lifestyle, sedentary lifestyle, and eating most of the foods that we have no business eating. Genetics certainly plays a role in this, and a thing called sleep apnea. How many here are familiar with sleep apnea? If you're my patients, you better all be familiar with sleep apnea, all right, sleep apnea affects about 5% of the population, and what it amounts to is the most common form of it is obstructive sleep apnea. You stop breathing at night. So if you're snoring heavily, you may have obstructive sleep apnea. If you find yourself sleepy during the day, not refreshed after sleeping, you may have obstructive sleep apnea. Now, daytime sleepiness and difficulty staying awake during the day is not always because of sleep apnea, but it's one of the things that needs to be checked. And it's so easy to screen for that it should be part of every single physical exam. This is an Epworth scale. It's a very easy, quick 2-minute screen in terms of what do you do. So do you get doze off? Do you get slight chance, moderate, or high chance of dozing off under any of these circumstances? And if the answer to that is yes, so that the points add up to over 10, then you need to be considered for a possibility of having sleep apnea. All right? Sleep apnea, people think of sleep apnea in large, obese individuals. All right? And yes, they are at greater risk in terms of sleep apnea. However, if your neckline is greater than 16.5 inches, if you have a somewhat recessed jaw, these all put you at risk for sleep apnea. So you don't have to be overweight to have sleep apnea. You can, in fact, be slender. And it can be a very, very serious problem. So serious, in fact, that if you have sleep apnea and it's untreated, we're talking about a potential decrease in lifespan of up to 9 years. Increased risk for stroke, increased risk for hypertension, and metabolic syndrome is part of the problem. Sleep apnea is an inflammatory condition, as is metabolic syndrome. So just something that you want to think about. What we see in metabolic syndrome, and the reason we're talking about it here, is because it's an inflammatory state in the body. So these same markers that I mentioned earlier that we have all seen now in chronic pain and chronic depression patients, we're seeing in metabolic syndrome. So metabolic syndrome is an inflammatory state in the body. And what do we see increased risk for with metabolic syndrome? Well, type 2 diabetes, non-insulin dependent type, heart disease, stroke. But what about pain and depression? Because that really hasn't been discussed a lot in the literature. As far as metabolic syndrome being a risk factor? Well, the answer is it is a risk factor. So in women with fibromyalgia, they were 5.56 times more likely to have metabolic syndrome than controls. Chronic neck pain, the relative risk is 2.1 in males and 1.5 in women if you have metabolic syndrome. 50% greater occurrence of depression if you have metabolic syndrome. So we see both a clinical correlation in the occurrence of metabolic syndrome, pain, and depression, as well as we see the inflammatory markers going up. So the presence of metabolic syndrome is a problem. How do you get rid of it? You need to lose weight. Basically, you lose 10% of your present weight, and that'll flip over most of your metabolism so that it'll decrease your risk. Aerobic exercise, 30 to 60 minutes a day. Walking 5 miles a day will also be effective for you. And you can go online if you've got an iPhone, and there you can download an app called Pedometer. It's free. You turn that on and it'll clock how far you're walking every single day. And that which is measured changes. So it is worth getting that app, costs you nothing, and start measuring what you're doing. Anti-inflammatory diet, which we'll talk about a little bit later. Plant sterols, 2 to 2.5 grams a day. Green tea, about 2 cups a day, 3 cups a day. And you can get decaffeinated green tea, which can be very healthy and effective for you. And the good news is dark chocolate. But it's got to be the good stuff. You got to be doing 72% or better cocoa concentration in it. And about 1.5 ounces a day, not a pound. You don't get to have the entire, in America we get these chocolate bars that are this big, and it's like a serving. It's not a serving. It's several servings. So 1.5 ounces of dark chocolate a day actually helps lower blood pressure, actually softens the artery so that they're not as stiff, they're more compliant, and they're less risk for stroke and less risk for heart disease as a result. It'll also improve your mood a little bit. You get a little bit of endorphin boost out of it. So 1.5 ounces a day of dark chocolate. Other treatments, oral magnesium supplementation lowers the fasting glucose and lowers the high-density lipoproteins. Doses up to 360 milligrams per day or to bowel tolerance. So what happens with magnesium is you can get diarrhea. Right? Phillips Milk of Mag for those who have constipation. So what you want to do is start slow and gradually work it up. So you start, and we use where are we? There are different forms. There's magnesium citrate and magnesium glycinate, which tend to be better absorbed than some of the other forms of magnesium. And so starting at 120 milligrams a day and gradually increasing it every couple of days, as long as your stools aren't getting more frequent and loose. If they are, then you need to back off. Omega-3 fatty acids and flaxseed oil, somewhere between 1.5 grams to 3 grams a day. There is some controversy about omega-3s. There's a suggestion that it may have an increased risk for prostate cancer in males. I think it's still debatable, and I think the risk versus the benefits of omega-3s in our diet the benefits far outweigh the risk. And so I'm still encouraging people to be taking about 1.5 grams. And again, depends on the condition. I may go up to 6 grams a day of omega-3s. Combination. Flaxseed oil also has omega-6s in it. In addition to the omega-3s, it turns out that we need some of the omega-3s. So combining those two is probably the best route to be going as opposed to just one. Aloe vera supplements, they're not yet on the market. This is very recent research. But there's this extract of the plant leaf in aloe vera that will be on the market probably in another year that has been shown to be very effective in improving glucose tolerance and lowering insulin resistance. So that will be coming. The studies are pretty strong on that. And then high fiber diet. Obesity. Obesity and being overweight. Okay, so we've looked at metabolic syndrome, clearly an inflammatory state, clearly associated with depression, clearly associated with pain. Obesity. Obesity is a body mass index of greater than 25 kilograms per meter square. This is overweight, rather, I'm sorry, up to 30. All right? You can calculate your BMI by, there's a bunch of websites that you go to, just put in BMI calculator and add in the numbers, which you need to do, which is your height and your weight, and it will calculate out what your BMI is. Obesity is BMI is greater than 30 kilograms per meter squared. 65% of all adults are either overweight or obese in the United States. This is the new norm, and it ain't normal. We have a problem. Overweight and obese individuals have a significantly higher percentage of back pain, chronic headache, migraine and tension headache, osteoarthritis, fibromyalgia, and abdominal pain. This is because being overweight and obese are inflammatory states. As far as depression is concerned, again, you see 55% increased risk of developing depression for individuals who are obese, and you see a 58% increased risk of becoming obese in individuals who are depressed. Reciprocal relationships in these things. Obesity, overweight are risk factors for depression and pain, and they are inflammatory states. The largest endocrine gland in the body is fat. Okay, endocrine is a gland that produces a substance that has an action elsewhere. Thyroid gland produces thyroid hormone that acts throughout the entire body. Fat actually is an endocrine gland. It produces a variety of substances, most of them inflammatory, that have actions elsewhere in the body, also in the central nervous system. So all of these factors are signaling molecules that set off inflammatory actions in the body. And the main issue, of course, is overconsumption of food and the types of food we eat. When we talk about inflammation, and I'm not going to go through all that for a sec, but when we talk about inflammation, everybody gets very confused. Because what is inflammation? Inflammation is a lot of different things in the human body. And it does a lot of different things. So if you have allergies to ragweed, and you have teary eyes, and you have a runny nose, that's inflammation. All right? The mucosal membranes are inflamed, they're irritated. The cause of it is a release of histamine as a result of contact with things that you're allergic to, the ragweed. The treatment for it is get yourself out of the exposure to the ragweed, but also antihistamines. Now, aspirin is a lovely anti-inflammatory, right? Would you take aspirin to take care of an allergic reaction? No, because it's a different type of inflammation that it's treating, and it's a different type of inflammation in the body. If you get a cut, and the cut gets infected, and the skin is superficially infected, all right, that's an inflammatory reaction in the body. That's mediated by white cells in the body, and you would treat that with an antibiotic, which would not be effective for treating hay fever. The type of inflammation we're talking about here is an inflammatory response that occurs in the central nervous system. It's not completely unique to the central nervous system. It has communications with the peripheral inflammatory factors, but it is different than the inflammation of, say, allergies or, say, an infection. Okay, does that make sense? Because it's very important we get this distinction, because every type of inflammation in the body needs to be treated differently. Can't treat them all the same. But in the case of the inflammation that occurs in the central nervous system that leads to depression, that leads to sleep disturbances, that leads to generalized pain syndromes, these can be directly linked back to our diets. These can be directly linked back to obesity, being overweight, and having metabolic syndrome. So our lifestyles, our diets, have a very significant impact about inflammation that goes on in the central nervous system. And there are very severe consequences for that. This is more complicated than it's worth going through, but this is basically talks about how excess sugar in the body and excess free fatty acids become inflammatory in the system. And it's a result of activation of reactive oxygen species, ROS. So if we look at what is an inflammatory diet? Well, actually, the standard American diet is an inflammatory diet. And this is the problem. Gluten in any and all forms. All right? Pretty much, we almost got this pyramid right if we had simply gotten rid of the bottom part of it. So if that's more your diet, you're actually pretty much on an anti-inflammatory diet. And there are a number of different diets which people have devised: the Mediterranean diet, the Okinawa diet, the Paleo diet, all of which help reduce inflammation in the body. Because what they do is they give you your foods, your proteins, that you need to break down in your system in such a way that they don't break down very fast, which refined carbohydrates do, all of our breads, and thus they don't cause that insulin spike, which leads to that very complicated table I was talking about with reactive oxygen species and accelerated death of mitochondria, which are the energy engines of the cell. So moving to these kinds of diet, and a paleo diet is basically, if it occurs naturally in nature, you're allowed to eat it. So next time you see a croissant tree, you're free to have a croissant. Until you see the croissant tree, you can't have one. And one of the problems that's happened with our grains and why grains have become such a problem for us is our refining process. So it used to be that we ground wheat with a stone. That was relatively inefficient. We now grind them with these ceramic grinders, and we create this really fine powder. The end result of which is it moves into our system faster, gets digested much faster, okay, and causes the sugar spike and thus an insulin spike. So the grains, we have way, way, way too many grains in our diet, and we need to cut way back on them. So leaky gut. Leaky gut is a condition in which the integrity of the tight junctions in the intestinal mucosa is disrupted, resulting in a loss of the normal intestinal barrier function and malabsorption. What on earth does that mean? So here's the deal. Inside of the gut, inside of the small intestine and the large intestine, is outside of you. It's not until whatever it is we put into our guts, into our mouths and travels inside, crosses the mucosal barrier, the cells lining the intestine, and then enters the bloodstream that it moves into us. So everything inside the gut's outside of us, and it's not until it gets across that mucosal barrier that it gets into us. Now there's a couple of ways in which food is brought into the body, but we're going to focus specifically on these things called tight junctions. Tight junctions are the spaces in between cells, and they're lined with lots of immune cells. All right? And so their purpose is to allow only little tiny molecules to come in and enter from inside the gut to inside the bloodstream. If those are swollen, if they're open wide, what happens is large molecules start passing across the gut into the bloodstream. The body does not like large molecules. So it looks at large molecules and it says antigen, and it makes an antibody response to it. Now we have inflammation going on. And what will happen is with people who have leaky gut, they suddenly find they're allergic to more and more and more and more and more foods. So you went from finding that you were intolerant to one or two types of foods to over the course of a year or two, suddenly you're finding you're eliminating everything and the only thing you're allowed to eat is grapes, red grapes. It's nuts. And then we start on all these elimination diets trying to chase this thing, when in fact, this is the issue, and what we need to be chasing, we need to be focused on is how do we seal your gut. Now the good news is we do have to eliminate a lot of those foods early on, but we can probably give them back to you later on once the gut seals. So leaky gut is a very serious problem and occurs, unfortunately, under a large number of circumstances. So, ischemic bowel disease, the symptoms first that we're going through, irritable bowel syndromes, food sensitivities, joint pain, autoimmune diseases, SLE, rheumatoid arthritis, can all be attributed to leaky gut, as will celiac, we'll talk about in a minute. Depression, fatigue, and skin rashes. Look at this, leaky gut can create all of this stuff. Irritable bowel syndrome, problems with gas, bloating, diarrhea, constipation. All right? It is normal to have a normal, regular bowel movement 2 times a day. Should be large, well-formed stool. If you're having a bowel movement every other day, every 3 days, every 4 days, you got a problem. It's not normal. The gut's not processing food properly. You're not feeding yourself properly, and you haven't got proper motility in the gut, and you haven't got proper digestion of your food. So we need to pay attention to all of these little symptoms because they build, they accumulate. And one day you say, everybody comes in. My history start with, when was the last time you were in excellent health, that you felt vital and strong? And everybody gives me a date. Okay? And then we start getting into their history. And so the last time I was completely in great health until one kid, mom brought me He was in perfect health, excellent health, until 6 months ago when he starts developing chronic daily headaches. All right, been through the mill of neurologists and pediatricians trying to figure out what's going on. But he was in perfect health, nothing wrong, nothing wrong. And I'm spending an hour and a half with this kid trying to get all this information. But he's healthy. 10-year-old kid, after all, how much could have happened? I go to do an exam on him and I look at his ears. There are tubes in both his tympanic membranes. So I turned around and I said, well, how long have those been there since you're not born with tubes in your ears? Oh, since he was 4. A lot of ear infections? Yeah. A lot of antibiotics? Yeah. So this is his 3rd set of tubes because every time they take them out, he gets infections again and they start another round of antibiotics. So people lie to me all the time. You're all very nice people. And I know you don't mean to lie, but the fact of the matter is when you really start getting down to it, you start to get this history of how these things accumulate over time. And the reason it's so important to know about this stuff is because the causes of leaky gut are in part antibiotics. All right? No one should ever receive an antibiotic without receiving a probiotic. Period. And how much probiotic? You should probably be taking about 25 billion colony-forming units of a probiotic a day. All right, some people can't tolerate that. We'll have them take 5 to 10. But if there's 100 trillion cells in the gut, 1,000 different species in the gut, 25 billion is still a drop in the ocean. So antibiotics, lots of them in particular, help cause leaky gut. Ischemic bowel disease, ulcerative colitis, Crohn's disease absolutely result in leaky gut. Stress. Anybody have stress? Stress causes leaky gut. Parasitic infections, non-steroidal anti-inflammatory medications. We'll talk about that in a sec. The cytotoxic drugs that we're using to treat rheumatoid arthritis or cancers, and excessive alcohol consumption and regular alcohol consumption. More than 2 glasses of wine a day will cause leaky gut. So in the anti-inflammatories, anybody here take Advil or Motrin? Anybody ever use that? Okay. Here's the deal. We are so focused on the gastritis that it causes, and the reason we're focused on the gastritis is because we got another pill we can sell you to do something for it. Because we never talked about how bad the ulcerations were and how frequently, and the answer is 3,200 people die a year in this country because of complications from non-steroidal anti-inflammatory medications. Okay? We didn't talk about them. We didn't talk about them because we didn't have a treatment. 32,000 hospitalizations result a year because of these medications. As soon as we started finding something that might help in terms of the gastric ulcers that they cause, we started saying, oh, by the way, there's a lot of people with gastric ulcers who are taking NSAIDs. And here's Carafate. Take this, that'll take care of that problem for you. Here's proton pump inhibitors that may help. This is a bigger issue. We don't talk about this, and it is in the literature. It's not subtle. So 60 to 80% of individuals within 24 hours of taking an NSAID, and 50 to 70% of people who are chronically using NSAIDs develop chronic intestinal inflammation. That is, if we take an endoscope down and we go look in your small intestine, we find that the whole damn thing's inflamed as a result of chronic use of NSAIDs in the overwhelming majority of people who are taking it. So chronic use of NSAIDs result in leaky gut. Not in everybody, but in the overwhelming majority of people who take them. All right? And what are the symptoms? Well, we put up with them. You take it once, and this is your response. This is the risk in terms of taking it once periodically, 60 to 80%. But if you start taking them on a regular basis, and the gut will heal. The gut basically turns over in about 5 days in all the cells in the gut. So the gut will heal after that assault. The question is, how many times do you assault it before it stops healing? That becomes the question. So yeah, once every now and then, not going to do you in probably. But on a chronic basis, and since 29% of the population is chronically using NSAIDs, we got a problem. And think about it, it's all this stuff adding up a little bit at a time, a little bit at a time, a little bit at a time, as we start creating these impairments and things that we put up with. We put up with gas, we put up a little bloating, we put up with a little bit of reflux. All right, and what do we do for the reflux? For the reflux, we take a proton pump inhibitor, okay? And what do we do when we stop the production of acid in our stomach? Well, acid isn't there so we could invent a pill to stop its production. Acid is there to help us digest our food and the first line of defense against bacteria and viruses that come into our body with our food. So to completely eliminate the acid is actually a stupid thing to be doing. There's a time and a place, and sometimes you have to do it. Okay, but there are other ways to go about treating these things, and we need to be smarter and more thoughtful about what we're doing. So there are specific tests that can be done in order to determine whether or not you have bacterial overgrowth and whether or not you have leaky gut. Okay, so what happens is there's a whole changeover in the flora in the intestine that happens as the gut leaks. And this is just an example of a small bowel bacterial overgrowth test. Basically what we do is we have you drink a fluid, lactulose, and we see whether or not you start producing hydrogen and methane from it. Over what time? The longer the time period out, the further down in the intestinal tract is the problem. All right, this is about 24 foot of small intestine. So the longer that is going up, and a difference of about 12 from baseline to the maximum, says that you've got significant bacterial overgrowth. Now, what does that mean? Again, we go back. There's about 100 trillion cells, bacterial cells, sitting in the gut. Now, the other thing you need to know is that that is most of the DNA in our body. So only 10% of all the DNA in our body is human DNA. And that's a tough thing to get your brain around, because all the rest of the DNA in your body is bacterial DNA. The DNA, it's found on your skin, it's found in the intestinal tract, it's found in the in the nose. Okay? We are just beginning to understand how important that other DNA is, because that other DNA interacts with our DNA, and it's that interaction that results in us. So studies are going on now where we're starting to look at the fingerprint, that is, all of the different types of bacteria that are in the gut and the concentration of the bacteria in the gut. That's not in your slides, unfortunately, but this is pretty new data that we're starting to look at. And we're asking the question, what's the relationship between the gut bacteria and our health? And what we're finding is in people who have obesity issues, and they say no matter what they eat, they can't lose weight, well, it may actually be true, because the composition of the gut bacteria in them is different than it is in other people. And so we're asking if we can change over that bacteria, will we be able to assist them in being able to lose weight? But it goes even deeper than that. We know that in certain pain conditions, a pain condition called complex regional pain syndrome, which is a really nasty critter which results in swelling and pain to just kind of gently brushing the arm or the leg that's affected. The composition of the gut flora in those individuals is significantly less diverse, and there's a couple of particular species that are significantly overgrown in those people than in controls, than in normal people. And we're finding in condition after condition after condition in diabetics that bacterial overgrowth, that change in the composition in the bacteria is directly related. We're starting to find correlations. We're also finding it in people who are depressed. So we may actually be able to take a stool sample from you one day and tell you what your problems are. So understanding that and being respectful of the composition of the flora of the gut, thus what we're putting in our mouths, and being careful with all of that, is critical in order for us to have excellent health. Treatment of leaky gut: stop all alcohol, stop all NSAIDs, the anti-inflammatory diet, treat any parasites or dysbiosis. All right? Most of the testing that gets done for parasites is ineffective, because the solutions that we use to transport the stool kill the parasites, and so it frequently gets missed on standard stool sampling. You need really to go to some specialized labs that are able to look for this stuff, have a much higher hit rate. And you'd be surprised how many people are walking around with parasites or bacterial overgrowth. And that needs to be addressed because that's part of the leaky gut syndrome. So that analysis needs to be performed. Treatment comes in the form of things like glutathione, N-acetylcysteine, L-glutamine, prebiotics and probiotics. And we're not going to spend a lot of time on that. There's another thing. There is a medication, by the way, for those who have irritable bowel syndrome. Again, it's bacterial overgrowth. So Xifaxan is a non-absorbable antibiotic. There are good trials that look at treatment with this medication for about 14 days and about a 30% resolution of irritable bowel syndromes in individuals who we treat with this. So again, there are medications in addition to supplements and dietary things that can all be done in order to address this problem. So you want to partner with your physician in talking about this stuff and figuring out what's going to make the most sense for you in order to diagnose and then address these issues. What you don't want to do is ignore the issue. L-glutamine, if you're going to use it, you use between 1,500 to 15,000 milligrams per day. It has to be cold because if you heat it up, you denature it, and so it's no longer effective. Dietary sources include animal proteins, raw spinach, cabbage, parsley, milk, and yogurt. Okay, so prebiotics. Prebiotics are essentially fiber, all right? And they're selectively fermented dietary ingredients that result in specific changes in the composition and or activity of the gastrointestinal microbiota. The microbiota is all of the bacteria that sit in the intestinal tract. So prebiotics, think of it as the scaffolding on which the probiotics actually need to settle in order to do the job they need to do. And probiotics are essentially fiber when all is said and done. Or prebiotics, rather. Probiotics, on the other hand, are live microorganisms which, when administered in adequate amounts, confer a health benefit on the host. Lactobacillus, Bifidobacter, those are the big family names of a multitude of species which are being studied for a variety of different health conditions. But overall, taking a good probiotic, and a good probiotic has to be refrigerated in order to keep the cultures live. All right, the yogurt that you're eating has maybe 1 billion CFUs in it, and by the time it's been transported, maybe dead, may not be. So what you want is therapeutically something that's live, not just put in so they can say they put it in. So you want to be taking a product which is preferably refrigerated and has some level of quality control on it, so that you know whether or not it is live probiotics and how many colony-forming units are in it. Saccharomyces boulardii, Lactobacillus, and Bifidobacterium are the species most commonly used for therapies. The Saccharomyces boulardii is one that you don't normally need to take, but one which has the longest track record in far as preventing the overgrowth of bacteria in the gut from antibiotics. So specifically, we get concerned about a thing called Clostridium difficile, which when you take antibiotics, if you end up with a severe diarrheal disease from the antibiotic, that's a consequence of the C. diff overgrowing in the gut. C. diff can rapidly take over most of the flora in the gut and be a real bear in order to try and get rid of it. The Saccharomyces boulardii, taken whenever you take an antibiotic, has been shown to be effective in preventing the occurrence of C. diff. Now, C. diff is a very interesting species. There's about 100 different C. diff species in the body. All right, some of them produce some really nasty toxins that are neurotoxins. And it has been demonstrated in some kids who have ADD, ADHD, some kids who have been frankly psychotic and depressed, that there's been an overgrowth of C. diff in their gut, producing chemicals that end up moving into the brain and interfering with the production of certain neurotransmitters, specifically dopamine. Stops the breakdown of dopamine, causes an increased amount of dopamine. The end result is all of these neurologic symptoms, these psychological symptoms. Right? So then you go start treating with ADHD medications. You use the Adderall, use the Ritalin, okay, or you're using antipsychotic medications. But really what you can do in some of these cases, if that's the problem, is an antibiotic that'll wipe out the C. diff, repopulate the gut with probiotics, and the whole problem goes away. Because they were being poisoned by an overgrowth of bacteria in the gut. So we want to prevent that from happening by using these things on a regular basis. All right? These, I think, are just kind of an everyday health profile worth doing. So 25 billion, 10 billion to 25 billion colony-forming units live, taken every day with food. That, the Saccharomyces bowleri, I only use when I've got people on antibiotics. And I use it for the duration of antibiotics plus 2 weeks. So this is, if you look at Gallen's website, he's got a really nice discussion on leaky gut and a whole bunch of ways to go about treating it. All right. The next issue is celiac disease, gluten sensitivities, and other food allergies. Celiac disease. All right, so celiac disease is an autoimmune disease. Celiac disease is a very, very serious disease. It is, as a 15% of the time, it will precede or be associated with diabetes type 1. It'll also, 5% of the time, be associated with hypothyroidism. All of the time, it creates a whole series of symptoms that we're going to talk about. It is an autoimmune disease as a consequence of genetically susceptible individuals triggered by gluten and related proteins in wheat, barley, and rye. Now, there's a trick here. 35% of the population has the genetic susceptibility to developing celiac disease. Only 3% of the population will ever develop celiac disease. So the issue is genetic susceptibility plus gluten plus something else that trips you off into developing celiac disease. One of the things that shows up repeatedly that precedes the development of celiac disease is leaky gut, a bacterial infection that somebody had, high stress period where they were having problems with gastrointestinal symptoms that preceded the diagnosis of celiac disease. The average time to diagnose celiac disease in an individual is 11 years. These problems go along a long time. Now, the other kicker is the average age of diagnosis now of celiac disease, all right, a genetic disease which we thought was predominantly happening in kids, is between the ages of 40 to 60. So if you have the genetic susceptibility and you don't have celiac disease now, it doesn't mean that you won't have it later. So if I end up testing somebody, and we can do genetic testing for celiac disease, and there's a very high risk of you having celiac disease genetically, but you don't have it, we take you off gluten. We want to see if that will actually prevent you from ever tripping over and developing celiac disease. We'll just get ahead of it. So you can think of this from a preventive standpoint also in looking at the genetic analysis. This goes back over the prevalence in the entire population. It's 1%. We don't diagnose it enough. Look at the number of people we're missing because we don't think about it enough. Typical age of diagnosis we talked about and the delayed diagnosis. And this is the other thing that becomes tricky in celiac disease. So the typical symptoms of celiac disease are intestinal, obviously, but there's lots of atypical symptoms that we don't think about, the end result of which is the typical celiac presentation is actually a very small number of the total number of people who have atypical presentation of celiac or individuals, either genetically susceptible people, who haven't yet developed celiac disease. So most of celiac disease isn't presenting with the typical signs. And the typical signs are diarrhea, weight loss, fat in the stool. That should never, ever, ever, ever be in the stool. If fat's in the stool, it's a serious problem and has to be worked up. All right? Bloating, lactose intolerance. Lactose intolerance. Anybody got lactose intolerance? So these are the common symptoms that you see with people complaining of who actually end up having celiac disease. Obviously, most of the people with these symptoms will not have celiac disease, but these tend to be fairly dramatic in people who have celiac disease, more so than people who have what we call irritable bowel syndrome. But the other symptoms of celiac disease are where everybody trips up. So iron deficiency anemia, chronic iron deficiency anemia, low-grade anemia that people call chronic disease. Yeah, it's chronic disease. If you didn't go look for celiac disease, you may have missed it. All right? There's skin rashes that are particularly unique to celiac disease, chronic fatigue, ADD, ADHD, early osteoporosis. If you're in your 40s or your 50s as a woman, or a man for that matter, and you start developing osteoporosis, the next question that has to be asked is, do you have celiac disease? Joint pain, autoimmune diseases that we already talked about, infertility. Infertility, women who are having trouble getting pregnant need to be checked for celiac disease. It is one of the presentations of celiac. Migraines. All right, I have a patient in my practice. Her presentation for glucose intolerance for celiac disease was migraines and panic disorders. She was seeing a psychiatrist and a neurologist. All right, so the neurologist is treating her migraines for her migraine problem. The psychiatrist is going on and on about how come you have, what trips off these panic disorders, what was your childhood like? Her childhood was pretty damn idyllic. She had a great life. She was extremely competent and successful in her career. What he should have been asking is, what are you eating before you have your panic disorders? Because that sandwich you had for lunch is probably what's tripping it off. But we think of psychiatric diseases as psychiatric diseases, and we think of pain or migraine as pain diseases. They are neuroinflammatory diseases. And we have to go look for the cause of the neuroinflammation. Vitamin deficiency, vitamin D, people who have a devil of a time keeping their vitamin D levels up, in particular, the fat-soluble vitamins, A, D, K, are the ones that you've got to be paying attention to. All right, now this is a controversy that we get into. This is the type of testing that can be done for this, and I just gave this lecture at a medical conference over the weekend, which is why this slide's in here. But what you need to look at is sensitivity and specificity, okay? Sensitivity is of everybody who has the disease and everybody who might have the disease, how many do we pick up? And the answer is these tests, especially down in this region, are pretty sensitive. So they don't miss a lot of people who have the disease, but they're going to pick up some people who don't have the disease. On the other hand, when you go to the specificity column, it's how many people are going to have this test positive that actually have the disease. That is, we won't get false positives. So as you look at these numbers, if you get a couple of these tests that are positive, you can make a diagnosis of celiac disease based on the blood work. Now, so there's a 4 out of 5 rule that's promulgated by the Europeans and is ignored by the Americans. So the rules are, if you have signs and symptoms of celiac disease, and as you've seen, the signs and symptoms are quite extensive. If you have positive serum celiac disease autoantibodies, those are the ones I just showed you. We're going to skip over this. If you have a response to a gluten-free diet, and if you have the genetic risk. Small intestine biopsy is virtually 100%. And that's what we insist on in the States. Okay? So I just ran into a situation where I had diagnosed a woman, an adolescent, who has celiac disease. All right? She's been worked up in a multitude of centers for chronic pain problems. I think of it as a neuroinflammatory disease, so I say, okay, what causes neuroinflammation? I start down my checklist. We look at celiac disease, and sure enough, she lights up straight across the board with all of the markers. Not one, not two, but virtually all of them. Okay? So I said, you have celiac disease. She went to the celiac specialist at a local hospital who said, nonsense, you can't make the diagnosis based on that. I don't believe you have celiac disease. So he sent her for a biopsy. The biopsy shows she had celiac disease. You can make the diagnosis on the basis of the lab work and with a proper history and physical. So not everybody needs to go to endoscopy in order to prove that you have celiac disease. Our blood tests are adequate along with the rest of the history in order to make the diagnosis. So we can save you that procedure. Neurologic symptoms that we see in celiac disease, and again, look at the list. Okay? Psychiatric disorders, depression, ADD, ADHD, anxiety disorders, migraines, carpal tunnel. All right? And it's not a small percentage. Even seizures can present as celiac disease. We have to be thinking about these things. if we recategorize these diseases as neuroinflammatory diseases, becomes one of the questions we ask. All right, gluten sensitivity is a different thing than celiac disease. So gluten sensitivity has a lot of the same symptoms that celiac disease has, but it's not an autoimmune disease. Okay? So it looks like, so people who have celiac disease can't have gluten, period. Ever, never, done. No gluten. It's going to immediately incite an inflammatory response in your body. You're going to be sick as a dog. And certainly my celiac patients who we've gotten off gluten completely know when they have been glutened. They get sick. So gluten sensitivity, on the other hand, in about 6% of the population, so where we had 1% of the population have celiac disease, 6% of the population we know is gluten sensitive. And we're not sure what it is exactly what the immunology of this disease is, but we know it exists, and we've had it well documented. So the symptoms: headache, brain fog, depression, numbness in the extremities. But you go back in terms of gluten sensitivity, and the way you make that diagnosis is you take people off gluten for 6 weeks. All right? And the way I make that diagnosis is I give them a very specific diet: rice, fish, chicken, fresh fruits, and vegetables. If it ain't on that list, it ain't on your diet. Nobody likes me when I put them on that diet. There's 2 weeks where you go through a really difficult period because you may actually have withdrawal from being off some of these foods, and you have cravings for them, and you don't feel as well, and then your brain starts to wake up. And you suddenly realize you've been dragging, and your energy hasn't been what it should be. And as your brain starts to wake up, you start to feel better. The problem comes in at 6 weeks now. At 6 weeks, you feel better. You've got more energy. You've got less aches and pains. You're sleeping better. You're feeling refreshed when you get up. And then somebody comes to me and says, okay, now what do I do? Well, now you have a choice. You know what the food does to you. If you eat it on a regular basis, you go back into the fog. If you take it out of your diet, you're out of the fog. We have to get you out of the fog first so that you know you're in it. Then you can be a little clear-headed about thinking about what it is might also be coming to play here. The other thing that looking at, look at these numbers in terms of vitamin deficiencies by the average American, okay? These numbers date back to 2011, but 34%, 25% on vitamin C, 70% on vitamin D, and D is essential for functioning of the innate immune system, okay? And we're particularly harping on the innate immune system because the inflammatory mediators in the central nervous system, those things that are causing all of these symptoms of headaches, chronic pain, depression, anxiety disorders, are the innate immune system in the central nervous system. They need vitamin D to function normally. So getting vitamin D levels up and normal is crucial. Vitamin E, calcium, magnesium. Magnesium is particularly crucial also because, this gets a little technical, but basically there are receptors. The highest percentage of neurotransmitter in the central nervous system is glutamine. It is an excitatory neurotransmitter, and it needs to move through a receptor called an NMDA receptor in order to enter the cell. Magnesium molecules sit on top of this receptor, blocking it, so the neurotransmitter can't enter. When you have a deficiency of magnesium, glutamate moves into the cell rapidly and readily and keeps them in a hyperexcited state. That hyperexcited state results in sleeplessness, pain, and so agitation. So checking how much magnesium is in your system and making sure that you're getting adequate magnesium and knowing that 35% of the American population is deficient in magnesium is a rather important thing. More than a couple of years ago, but when we first started working with magnesium, we had a couple of women who had been through fairly extensive workups trying to get pregnant and fertility problems. And they had failed a couple of in vitro processes. And we checked them for magnesium, not because we were thinking about anything about fertility, but because we were treating pain problems with them. And we found they were significantly low in magnesium, and we gave them magnesium, and it was successful in terms of helping with their pain, but they then came back several months later and announced that they were pregnant. And then we looked in the animal literature and found that magnesium deficiency is associated with infertility. And we passed that information on to a couple of our colleagues who were in the infertility field, but nobody seemed to be interested. So, it's not where we do our research, but it's something easy to think about. The catch and the problem with magnesium is that 60% of magnesium is in the bone, 38% of the magnesium is in the tissue, and only 2% of magnesium sits floating around in the blood. When we measure the blood levels, the only thing we can find is end-stage disease if it's there. We don't find earlier signs of the disease because that blood level is preserved at the cost of the intracellular levels. So you will have no magnesium left in your body at the point that the blood levels say you're low. So measuring blood levels is a waste of time. So you have to figure out a way to measure intracellular magnesium. There's a couple of ways to do it. We use a test called intracellular diagnostics, and it's proven to be a pretty stable test, meaning that it's reproducible. We can send out multiple samples from one individual and get the same result back. So you can do that with RBC, red blood cell magnesium levels also is another way to look at it. We've used that test. We have not found that test to be as reliable and as stable, so this is why we go back to this test. In this particular case, you see a magnesium level of 31.5. This was a 24-year-old woman who had generalized pain, fibromyalgia, and sleep disturbances. Her levels, when you start getting down to 30 on a magnesium, you're at risk of sudden death from heart attack, from cardiac arrhythmias. So this is a very serious low level of magnesium. Women in particular are susceptible to magnesium deficiencies because of blood loss from the menstrual periods. So magnesium deficiency, and this is why we get back to my recommendation that we saw earlier of taking upwards of 360 milligrams of magnesium a day. I told you somewhat about this case, and these are the results of her antibody testing. There's nothing subtle here, right? And I got another doc who's supposedly a celiac expert arguing with me. Her risk, interestingly enough, was only 2 times greater than the general population. This is a genetic test that we do. It's called Prometheus testing that we run on them. But nevertheless, it puts her at an increased risk. It doesn't seem to matter whether or not you're at increased risk. It only matters what level increased risk, rather, that you're at. It only matters that you're at increased risk. So the genes are there that can be triggered. This was another case that we're treating. This kid, very severe depressive disorder. And again, he's being treated for a depressive disorder. And suicidally depressed. And we found, again, because we think these are neuroinflammatory diseases, and looking on him, he's got celiac disease. We take him off gluten, and his brain starts to wake up. Now, it's more complicated than that. Gluten isn't always just the answer, because he's got a leaky gut, and we've got to address that as well. We also have to take a look and see whether or not there's an overgrowth in the C. diff species I had talked to you about earlier. So, again, in him, there's no subtlety here, and there's lots of internal consistency. And there's an explanation for why this IgG would be off, but you don't need to be concerned about that. But all the IgAs are positive, all of them. And again, not subtly so. We don't make a diagnosis of celiac disease lightly, but when it's there, it's there. His risk factor genetically is 10 times. Now, we did a bunch of food sensitivities on him, and we find this is what we see in a leaky gut situation. Look at all the sensitivities that he's got to other things. Sesame seeds, coffee, various types of components of milk, okay? And some of the grains that are typically used to substitute for gluten. So you've got to be very careful, and it's not unusual to see a lot of this crossover in people. So until we get the gut sealed, we're not going to be done with this kid. We got a lot of work to do with it. So, central sensitization syndrome is a neuroinflammatory disease. Chronic pain, depression, anxiety, post-traumatic stress syndrome are symptoms of a neuroinflammatory disease process. You treat the cause, not the effect. Cause is neuroinflammation. In this particular case, we want to look at metabolic syndrome. We want to look at obesity. We want to look at leaky gut. We want to look for celiac and gluten intolerance. We want to look at vitamin and mineral deficiencies, all coming into play, potentially contributing to or potentially being directly causative of the disease. We also look at neuroinflammation as a process. So in medicine, we tend to look at life as an event. This happened and then I got sick. When in reality, a lot of things have happened that have led up to the tipping point that brings you into the office. And if all we're focused on is the tipping point, and we miss all this stuff beforehand, we miss the diagnosis, and we miss the opportunity to actually get you cured. We can treat symptoms galore, but we can't cure you. So hypoallergenic diet, rice, fish, chicken, fresh fruits and vegetables. We let people have olives and olive oil and a little bit of red wine, but nothing packaged, nothing processed in any way, shape, or form. A patient of mine just sent me a video of somebody who had gone into a McDonald's and bought a chicken McNugget and then proceeded to stick it under a microscope and look what was there. All right, they found inorganic fibers as part of the chicken McNugget. That's not food. It's not even a food substitute. So, you know, we need to pay attention to what we're eating. We need to be thoughtful about what we're eating. And when we put people on this diet, it does not eliminate everything that you may be potentially allergic to. But what it does is it gets rid of all the big things. And so that fog starts to lift. And then to be effective on this, the next thing you need to do is to keep a bit of a log. You need to become mindful about what it is you're putting in your mouth. You need to pay attention to how you feel after you eat things. And it's particularly helpful if you're writing down periodically, and we'll have people just keep a list, what's your energy level, 0 to 10, 10 being best. What's your pain level, 0 to 10, 10 being worst. Okay? Any issues with brain fog, any issues with irritability, your mood, rate it again on a 10 scale. That's it. And do that log periodically throughout the 6-week period that you're on the diet. And then start seeing how you feel when you eat various foods. If you eat something and you find that you get nasal congestion, you shouldn't eat it. Your body's telling you you're allergic to it. If you eat something and find you wake up the next day and you're really stiff and you're really sore, don't eat it. So this is the beginning of the discovery process of what it is you can and should not be eating. So we went through a lot of material. We covered a very broad spectrum. This is not about eat this and you're all better. Okay? This is about taking care of ourselves in a total manner in which we're paying attention to all the foods we're putting in, we're paying attention to all the symptoms we're having, and we're doing what we need to do to change our lifestyle and our eating habits in such a way that we can remain healthy and reduce the inflammation in our body. That'll start reducing the pain, that'll start reducing depression, anxiety disorders, and allow us to return to complete and total health.